Hello, and welcome to another edition of Health Solutions with Sean and Janet Needham, where Team Needham discusses everything healthcare. I am your host, Sean Needham, along with my beautiful wife, Janet, and our producer, Lindsay. We are streaming live from our studio in Moses Lake, Washington today. And as always, you can catch us on my personal Facebook page and the Moses Lake Professional Pharmacy YouTube site, streaming live every Monday, 1 to 2 p.m., and our midweek podcast usually is on Thursdays, 8 to 9 a.m. Stay tuned for those, though, because those sometimes do move around depending on our guest schedule. And you can always also find these on, it's a podcast, right? So you can find them on all the podcast forums like iTunes, SoundCloud, iHeartRadio. Those are usually available a couple days after we stream live. So make sure you go to those forums. Make sure you go to the Moses Lake Professional Pharmacy YouTube site and subscribe to it so you don't miss any episodes. We really, really appreciate it. And comment on our Facebook Live or message on Facebook in general. So with topics or with comments, so we can always strive to make this podcast better. Today, we have another doctor on a line, and his name is Dr. Sean Hampton. He is in Pennsylvania at Hampton Medical Direct Primary Care, another direct primary care doctor. You know how we really support this format. Janet and I talk about it a lot on this podcast, and it's a free market solution to healthcare. And speaking of free market solutions and solutions in general, I wrote a book about this. It's called Sickened: How the Government Ruined Healthcare and How to Fix It. It is on Amazon in Kindle version, working on the audio version now, working on the paperback version also. And one of the fixes, there's a 6-step solution, because we are all at Health Solutions. We're about solutions. It's in our name. There's a 6-step solution on how to fix healthcare. We don't just complain about it. We have steps to fix it. There's a 6-step solution. And one of the steps in that solution is direct primary care. So I appreciate doctors like Dr. Hampton stepping out and going into a direct primary care model so he can still be a doctor, because we were just talking before the show. There's a lot of healthcare professionals, whether it be pharmacists or whether it be doctors, that are so tired of the system, they just get out of it. Dr. Hampton has a friend that is a pharmacist, and he is laying concrete. He got so upset with the system, he quit as a pharmacist, sold his pharmacy, and is laying concrete. So I'm going to let Dr. Hampton kind of interview himself and tell a little bit about his story. Dr. Hampton, welcome to our show.
Thank you. Thank you, Sean and Janet, for having me. I really appreciate this. This is something that I'm very passionate about. You know, as you said, we're in a state of disarray with our medical system. And, I think we've already had this conversation, Sean, that, the solution, I believe, is going to be a grassroots solution. It's going to come from pharmacists such as yourself and, physicians, whether they be primary care physicians or specialists. They're going to say, hey, this system doesn't work. And the only way to improve this system is to, build something better and new. And, as of now, the only fixes have been from the top down. And, we discussed that perfectly. I've read many articles about it. If you try to change a system or fix a system that's entirely in disarray, it's just going to create, more havoc and, more issues down the road. So I really think what you're doing and what direct primary care is trying to do is, build something from the ground up that I really believe is going to help. So you said, interview myself personally. I graduated residency in 2013. And actually went to private practice with just me and one other doc. And we were on call 24/7. I did outpatient care, I did inpatient care. I also worked in a nursing home, and I even did a little emergency room work too. So, I think I did the full gamut of what you would call primary care. And I'll be honest, I loved it in the beginning. I really did. I loved, seeing my patients in the office. I loved following them in the hospital. And I enjoyed, nursing home care. I actually got to work with veterans. So I worked at a veterans home in the state of Pennsylvania. So I really enjoyed that. And I thought that was a privilege and an honor to be able to take care of the veterans. But at the end of the day, and especially at the end of a couple years, I realized that, even to keep the doors open, you had to see 20 people a day. And to be successful, you had to see 25 to 30 people a day. Now, for your viewers out there, 25 to 30 patients a day equates to about an 8-minute visit. Now you could say, oh, isn't there a 15-minute visit? Not really, because out of that 15 minutes, you'll get about 8 with me. And they've done studies. And the studies say that a person gets about 3.5 minutes to talk during an office visit. Now, I don't think that's enough time to help with the many medical issues that Americans face today. And as we've discussed, I don't think it's enough time to deal with complex chronic medical conditions either. And that's where, the majority of spending in America, that's why we spend more per capita than pretty much any other industrialized nation in the world. And yet we have significantly lower outcomes than those same countries. And I think that really comes down to our inability to deal with complex chronic issues, complex chronic medical issues. And, I think to really move the needle and to improve care, we first need more time with a patient, because if the patient doesn't feel like that you're, as a physician, that you're in their corner, then I think their ability to deal with those complex, chronic medical conditions is much less. So, that's one of the things I realized after about 3 to 4 years in primary care in traditional type family medicine setting. And I wasn't even employed by a large entity medical system telling me how to practice medicine. So, I think I had it better than most docs out there. I have a fellow physician, you should have her on. She worked for a large system out in Philadelphia, and she would tell me things I was appalled by. Like, if one of her patients called in during the day and they needed something, she wasn't allowed to see them. She had to send them to urgent care or the emergency department, because the hospital system would make more money from that particular issue. And that's what it comes down to, is that if you run medicine like a business, you're going to have people making decisions that obviously increase revenue, but are going to harm patients, and are going to, lead them through unnecessary testing, unnecessary referrals, and, probably seeing more specialists than they need to. So, back, whatever, I guess it was 7-8 years ago, that was really what started all this, where I was like, this is not the way I wanted to practice medicine. I don't think this is right. And I kind of had a little burnout at that point. I really did. So I actually parted ways with that practice, and I went to urgent care for a little bit of time and realized, I liked it. I did emergency medicine for a little bit. So, I enjoyed it. But I also felt like I wasn't helping anybody, and I also felt like anybody could do that job. It's a hard job, urgent care. I don't mean to belittle anyone that does it, but pardon me. But, it was something that I was not passionate about. And if you're not passionate about what you're doing, then first of all, your patients will notice that. And secondly, I don't think you'll get really good results, so to speak. So I've always was interested in concierge care. Actually, I didn't know anything about direct primary care. Mm-hmm. So I started to do some more research, and I realized that although I like concierge care actually bills insurance companies and they bill the patient. So they kind of bill both, which I always thought was illegal, but apparently they can do it. And, I wasn't just interested in seeing people that could afford me. I wanted to see everybody. I wanted to see the blue collar workers. I wanted to see, people that couldn't afford insurance, and I wanted to see people that valued, my time, and valued my opinion and wanted a different approach to medicine. So, I saw direct primary care, and I was just blown away by it. The nice thing about direct primary care is that I had a lot of docs out there that immediately wanted to help me, and they didn't want anything in return, and I love that. I was like, wow. And, you've had a few of them on your show.
Yep.
they all wanted to help and they wanted nothing. And, I do the same thing for people that reach out to me today, like, hey, let me know how I can help you. And I think that was what really got me into it. And, I just kind of made the leap, and it was a leap where I said, we were going to move where we were from. We're in central Pennsylvania, right near Penn State. So we're in a small town/city in Altoona, Pennsylvania. And we were about ready to move out of town. Me and my fiance, we were going to move to Manhattan. She grew up in Long Island. And that fell through. So I was like, you know what, let's just do it. So I think we had a little bit of money in the bank, and we're like, all right, we're going to lose it. We're going to lose it. So we opened the practice in January of 2019. And to start out, I subletted from a friend of mine who's a chiropractor. I literally started the office in a 10 by 12 exam room, one room, and 0 staff except, my fiance, she was basically like a on the couch staff member, so to speak. So she was at the house, and I would bounce stuff off her, and she would take care of it, and I would answer messages throughout the day. And we had appropriate growth. I was working full time in urgent care still. Didn't really tell them in the beginning what I was doing, but after a while they figured it out, and they were pretty cool with it. But yeah, we had appropriate interval growth every month, which was about 20 to 30 patients a month, and that's really all I could handle. And since then, we've had appropriate growth. And, I think the movement continues to thrive because just people are fed up. They're fed up with the care they're getting right now. They say that the doctor interrupts after 12 seconds. That's the average time in which you get interrupted. And then total, you only get to speak for 3.5 minutes. So, I'm always back to that time frame. And in direct primary care, I spend an hour with each patient, brand new patient. They get a whole hour with me, and subsequent visits are 30 minutes long, and those are as many as they need. And if something comes up and they need an hour for a follow-up visit, they get an hour. So I think people really love that, is the amount of access and the amount of time they have with their physician.
Oh, for sure. I mean, because that's definitely a complaint with a lot of patients, and they don't think, unfortunately, and this is why we have a podcast and have physicians like yourself on, is that patients don't know any different. They just think that's the norm, and it has to be the norm. And our goal is to educate and empower people that they can be in charge of their own health. And that means, shopping around for their own doctor and finding other options. And back on the concierge thing, I know there was a group, a branded name of that, and it didn't really go over too well that I know of. And here's what my thought is, and a lot of your colleagues that are direct primary care doctors have probably told you this also. And if you're in any of the forums, Facebook groups or stuff that about direct primary care is, and this is mainly for our listeners and viewers, or also for our listeners and viewers. If a doctor, in my opinion, if a doctor says that they're doing concierge medicine and they're also billing insurance, I don't believe that you can do both and give good service to either. It's either all or nothing, in my opinion. And a lot of doctors are scared to, they want to still keep a couple insurances and all that. But in my opinion, it's all or nothing. And I know when Jan and I billed some insurance, until we went no insurance whatsoever, that's when we had to make it work. And that's when I think the patients got better care too. So I don't know if you have any comment on that, but it's a big leap of faith. But, I think that's what I like to educate potential patients about, is that, if you can find a doctor that has billed no insurance, it's probably the best.
Absolutely. I think I'll quote one of my DPC colleagues. He said, trying to run a hybrid practice is like trying to run a vegetarian steakhouse.
I saw that floating around somewhere. That's an awesome one.
Yeah,
that is
Josh Umber. Yeah,
it was Josh Umber, who basically, thank goodness Josh started this revolution pretty much, right?
Absolutely. Yeah, he was one of the people that helped me out in the beginning.
Yeah,
100%. So
the information he gives to people and stuff, all for free, is just unbelievable. And you know what it says? It just says that doctors do. In the right situation, doctors do have a passion for medicine. They really do. Absolutely. And the ones that are disenfranchised are usually in a big group type setting, and they are literally, their hands are literally tied and they're slaves to the system, and they don't like it. And those doctors get picked on for being burnt out or being grouchy or whatever. But in a lot of ways, I don't blame them, because they're in a system that just totally controls them. So kudos to you, and thank you for sharing that story. So I would like so in the past, when you were, back when you first got out of residency, when you were seeing a diabetic, for instance, and you could see him for 8 minutes. Show us, tell us how it compares today, seeing a diabetic, 7 years ago, and then seeing a diabetic now in your DPC practice. Tell us how that compares.
Well, I'd say the biggest comparison is that, in my practice today, I actually sit down with them and, number one, don't feel rushed, and they don't feel rushed. So, I always like to say there's 3 tenets to what I do. It's access, time, and value. So, if we have more time with the patients, then we provide, more value with the outcome, so to speak. And when I spend more time with a diabetic patient, I get to figure out what they're eating, because turns out, contrary to popular belief, diabetes can be cured. It really can.
I love it. I love it.
Yeah.
Now we're going to have some haters out there. I'm just being honest, because I've been in these forums before. So let's define the difference between type 1 and type 2 diabetes.
Please.
And we could talk all day about it, but still both of them need diet controlled, and you can please go into that. But let's go ahead and define that.
Yeah, because they'll tell me to go back to medical school. And
I've been told that. Well, you don't know what you're talking about, because you say that type 1 diabetics have to watch their carbs. Oh, they do.
Well, they do, but anyway.
Right.
No, type 2 diabetes, I'll plug someone else's book, but there's this nephrologist, Jason Fung. He wrote a lot of stuff about type 2 diabetes, and type 2 diabetes is a lifestyle condition. So, you're not born with it. It can be cured, and it can be cured through, diet, exercise, and absolutely medications. They're absolutely warranted in type 2 diabetics. But really what it comes down to is that if you work with somebody and you help to prevent them from using more and more medications, then you'll prevent the progression of the disease. And, unfortunately, in type 2 diabetes, as the disease progresses, patients get put on the worst medication that we could put on a type 2 diabetic. So we put them on insulin. And what is type 2 diabetes? Type 2 diabetes is actually being resistant to insulin. So what do we say? Oh, we're going to put you on insulin, even though you're resistant to it. And the number one side effect of insulin is weight gain. So we're going to put you on that. That makes sense, right?
Right.
So that's what we do. And I still do that to this day. So, nothing against endocrinologists, nothing against traditional primary care docs. I still do that. I still put people on insulin. But I tell them, unless you want to stick yourself with a needle 4 times a day for the rest of your life, you have to listen to me. And you have to eat the opposite of the, what we call the standard American diet, which is, the acronym is SAD. It's very sad. And, we can change it. It doesn't mean you have to go keto and never eat a piece of bread for the rest of your life. It doesn't mean that, but it means that we need to work on a lifestyle change that can be reproduced over time, because anybody can binge diet for 8 weeks, but it's coming up with a way of eating that can be reproduced over time, and a way of activity that can reproduce over time, because you can't just sit on the couch all day either. Humans were meant to move, especially from an evolutionary perspective. We used to have to forage for food. We don't so much anymore, but we used to have to forage for food, and we had to move, and we had to, so it was really all lifestyle things. So I get to spend a lot of time talking to people about lifestyle changes. I always make a joke that you don't need 11 years of schooling to tell someone not to drink soda and eat carbs all day, but it turns out you do. Because some days I feel very basic when I talk to people, because I say, I'm going to tell you 5 things, and your great grandmother told you all these things already. You just didn't listen. It was, get good sleep, try to move at least 30 minutes a day, eat a diet that is not the standard American diet. We can get into more detail with that. Don't abuse drugs or alcohol, and try to have meaningful relationships with the people in your life, or have a good social connection where you feel like you have a purpose. And your purpose could be walking a dog. Your purpose could be taking care of your grandchildren, or your purpose could be having a compounding pharmacy. So, all those things together all come together as good. And I really think if we start with those 5 things, we can build on it. And I always talk to people about a pyramid. At the bottom of the pyramid are those 5 things. And at the next step of the pyramid are eating well, maybe trying to improve exercise, maybe doing some other things to improve your health. So we kind of build on that. And to explain that in less than 8 minutes is next to impossible in traditional primary care. So that's what I really love about DPC.
Awesome. I love it. And in traditional practice, basically you would just prescribe another medication and tell them we'll get it filled at a pharmacy, and that's the solution, right?
Yeah, and I think that's easy. I mean, that's a reflex, and I think a lot of primary care docs do that, and they're like you said, they're stuck in that system of having to do that, and I used to do that. But I think when you prescribe it and you talk to them about why it is, and how we can maybe get off it in the future, and there is a solution other than meds, and you take that time to explain it to somebody, they leave the office and they think, well, he heard me. I'm going to start this medicine, but my ultimate goal is to, maybe not use it forever. And I think people really start to, kind of grasp that, that there's two people in a symbiotic relationship that can really improve the overall health of a person.
So Janet, do you have any comments or questions for Dr. Hampton? That's a lot of information. Thank you, Dr. Hampton.
Yeah, I know.
That's great.
I'm reflecting over our time of pharmacy and handing out medications with outcomes that just kept repeating themselves over and over without the positive outcome. And what I'm hearing so loudly from you is that you're actually able to communicate with your patient why it's important to them, so they actually understand and can buy into the therapy or the decision of what kind of care, and that improves their outcome because you didn't give them just a blurb, go do this. You explained to them why it's important for them to follow these steps and why that will make a change in their lives and why it's important. Because I think what we are selling people is that just go do what I tell you and just do it because. And unfortunately, as humans, we don't operate that way. We want to understand why it's important for me to choose this food over that food or what activity over that, because the doctor telling me to do something is over. I mean, that's my mother's generation, and she isn't even, she doesn't even buy that anymore. We have access to knowledge now called, on the internet. We can Google Dr. Google, and when I have patients that call me and say I've only been given answer 1 or 2 questions to my provider, I think it's really sad. So, kudos to you that you're able to actually communicate, because I think that is what is happening in your patients, is that they're understanding and they're buying into their therapy.
So let's talk a little bit about diet, if you don't mind, because it's so important. And at Health Solutions, we talk, basically you're preaching to the choir, because we talk about, there are basically 3 things that we can do. And the 4th thing we always talk about is relationships, but really it's diet, exercise, and rest. And those are the 3 things we can do to make our bodies healthy. That's really, it's that simple. And of course, we always say too that, we'll die without sleep before we'll die without food. So sleep is the most important out of all 3 of them. And we don't have to exercise to live. We can be healthier if we exercise, but we don't have to exercise to live. We've got to eat to live. So eating is second most important, exercise third. But let's talk about Jason Fong, nephrologist. I'm not sure, have you seen him speak at all?
Yes, I watched a few things on YouTube, and I've read the diabetes code. I haven't read the obesity code. But, what I loved about the diabetes code, I mean, it's a little medical based, but I think anyone can read it and understand it. But I read his book and I rehearsed it to patients. And because it makes sense, I love physiology. That's why I went into medicine. And it makes sense from a physiological perspective. And that's what I love about it. When you can back up physiology and talk to patients, I get them to understand what it is.
And help me out, but I believe he talks a little bit or a lot about intermittent fasting, correct?
He does. So that is actually something I personally do. And actually, I got my fiance to start doing it, and she does it more than I do now. She drives me a little crazy with it sometimes. But
well, educator, we've had Dr. Sean Amara. I don't know if you're familiar with him. He was on our podcast once, and he talked about intermittent fasting. Everybody's got a little bit different idea of what intermittent fasting is, but tell us what intermittent fasting is and what he talks about on the obesity code, and basically to give a little bit of a little bit of general idea of what his book talks about is, the standard American diet, like you said, the SAD diet, it's not what we're doing is not working. So we've got to do something different. And intermittent fasting, we could think about it being like totally novel, but if you think about how, ancestrally wise, we ate food, we intermittently fast all the time because there would be times we didn't have food. So go ahead and explain the concept of intermittent fasting and what hours, how many hours, and all that kind of stuff. Kind of go into some detail.
Sure.
Please.
So medical disclaimer: if you're on insulin or you're on diabetic meds, speak to your physician before starting intermittent fasting because it can have catastrophic effects.
Yep.
But intermittent fasting in of itself mimics how we used to live from an evolutionary perspective. We would basically have times of feast and times of famine, and it all came down to having to forage for food. So from an evolutionary perspective, our bodies are meant to go through prolonged periods without having to eat or to consume food. So the physiological basis behind intermittent fasting says that we store things in our body and we use them when we need them. But if you're constantly eating, you're never going to chew up or, use up your storage molecules in your body. Now we can say a bunch of fancy words and say it's this and it's that, but really it comes down to if we go through periods in which our body will use up those reserves, then we'll do very well, in the long term, so to speak. And, for all the people out there that are, listening and saying, I've heard my doctor say fatty liver, and that's huge, is that, a lot of people have fatty liver in the United States. And I'm a kid when it comes to medicine. I mean, I'm 39, but I'm a kid. And, the amount of fatty liver I've seen just in my 10 years in medicine it's huge now. Everybody I see has elevated liver function tests. I mean, I could literally tell you the algorithm for working it up off the top of my head, and it's a long algorithm. But that's why, and the reason we all have fatty liver is, you eat too much sugar or carbs, that stuff's got to store somewhere, and it stores in our liver. And that's where, Jason Fung talks about intermittent fasting, and where I preach it to my patients is that if we spend periods of time not eating, our bodies are going to eat up those reserves. And there's different ways to intermittent fast, but the most popular way is a pattern it's called 18-6 fasting. So you can either look at it as 18 hours of not eating or only 6 hours of the day in which you do eat. I always try to be positive and say, hey, you got 6 hours to eat, because people can buy that a little bit more. And what it is, I'll say, listen, you started at night. So you say, I'm going to quit eating at 6 p.m. Now, these are for people that work first shift. If you work second or third shift, then we have to have a different talk. But, you can stop eating around 6 p.m. at night. And, if you're hungry before bed, drink water or drink herbal tea. Okay. Go to bed, wake up the next morning. Hopefully you're a coffee drinker, because if you are, it'll make this a lot easier. If you're not, then maybe start. And you can't eat until noon. Now, the benefits of intermittent fasting really start to show around hour 16. So that 10 o'clock to 11 o'clock, that 11 o'clock to 12 o'clock, when people are kind of struggling, once again, drink water, drink black coffee, drink herbal tea, do something else, but really push through it. And the goals of intermittent fasting are many, but really what it comes down to is it regulates hormones in our body. And that's what Dr. Jason Fung talks about in his book a lot, is that, every single process that occurs in our body occurs through hormones, and weight gain or weight loss also occurs through hormonal changes. And that's how intermittent fasting really works in the body.
Wow. That's great. I love that. That was a great 2-minute conversation about intermittent fasting for sure. Janet, you have any questions about that?
Well, I see so many different things out there right now when you look on the internet, and they're talking about body types and you should eat more fat or this or that per your body type.
Right.
And I don't know how much that really plays into it, other than just maybe getting a good plan. I mean, what is your feeling on that? Because I keep seeing, like if you're this body part or type, or if you're this body,
Yeah, great question. My approach when I talk to patients is keep it simple, and to have a pragmatic approach and keep it very simple. because what we need to develop is a way of eating that can be reproduced over time. Like I said before, anybody can, basically do anything for about 8 weeks at a time. And believe me, if you spend 8 weeks only eating apples, you'll lose weight. I mean, any sort of binge diet or any sort of crazy way of eating, you'll lose weight. But really, I talk to people about what's your life like? How can we integrate a little bit of healthy food into that? And the way I love intermittent fasting is that I think people can wrap their heads around that, because if I tell you what to eat and you got to start cooking, you got to go to the store and you got to do all these things, not only is that time consuming, that is expensive. It is expensive to eat that well. And, people they don't have time. They have kids and they work, both parents work and, this, that, or the other thing. And I say, you know what? All you have to do is not eat. Sounds awful, but it's really easy, to do. Well, it's simple. Doesn't make it easy.
Yeah.
It's simple instructions, but they might not be easy.
Yeah. And our bodies are just, evolutionary wise speaking, we're meant to store fuel stores. Yeah. And our body's good at that, whether it be in the form of fat or glycogen. And, we store it for a time we need it. Unfortunately, we all pretty much as Americans have an unlimited food supply. I mean, I say that tongue in cheek, but that's really almost the truth. We have an unlimited food supply. So we never actually get to be catabolic and burn off that excess fat or that glycogen. And I mean, we could debate all day long about, keto and you don't need glycogen, you don't need glucose, but I'm going to guess it was interesting what you said about the fatty liver, because most of our glycogen is stored in the liver. So I wonder how much that has to do with us getting a fatty liver, is that most of our glycogen stores are in the liver. Because you're talking about eating carbs. Now, I wouldn't think that directly makes the liver enzymes elevated and it doesn't cause a fatty liver, but I don't know. Do you have any thoughts on that?
No, that's the precursor. I mean, high carbohydrate, it's the precursor. I mean, listen, I could speak in detail, but there's many other ways to get a fatty liver, but 80%, if you're not a heavy drinker and you don't have some hereditary disease, 80% of all people with elevated LFTs have fatty liver. You know what I mean? Doesn't mean I don't work them up for other things, but it's always diet. I mean, it's 80% of the time is diet.
So you have you have a success story of how you've gotten diabetics off of insulin. Is that correct?
Yeah. So I actually I had a really cool one. So I had one patient that came to see me. He was actually, you would like this as a pharmacist. He was on U500, so he was on so much insulin.
Whoa, he had to go
Yeah. We don't use U500. So for your viewers out there, U500 is concentrated insulin. So it's basically, 5 times the regular insulin. It's that concentrated. So he was on U500 and he was on long acting insulin too. So he was on 4 shots a day and he was on around 135 units a day. So that was a lot. And he was also on oral diabetic meds. And I think when I first saw him, his A1C was 13.6. So
it wasn't working. This was not working. Right?
No, it was not working at all.
Wow.
Yeah. And he was overweight and he had other medical issues. But so we spent a lot of time together. And I think the success, came from that collaboration between both of us. I always say, this is all you. I can show you what to do, but this is all you. And his wife was very supportive and, she was in very good health. So she helped with, his meal planning, et cetera, et cetera. And we basically walked him down, because you can't take somebody that's on that much insulin and just tell them, hey, don't ever eat another carb and quit eating, quit taking, start intermittent fasting and quit taking your insulin. And it's tough. So in the end, we have him basically down to about 35 units of insulin a day. And we're slowly walking that down even more. He's lost a substantial amount of weight, and he did really well. Now, unfortunately, not every success story in medicine has a perfect fairy tale ending. He recently kind of had a quote, relapse, and he kind of fell off the wagon. And as a result, he actually called me one day and he said, my blood sugars are back up. I don't feel well. I'm having to take more of my insulin. We did get him off U500. We just have him on regular insulin now. And he's like, plus, I think I have a hernia. And he called me, I think it was on a Monday. And I said, well, what makes you think you have a hernia? We actually spoke on the phone because In DPC, you have kind of complete access. That's one of my tenets of what I tell my patients: access, time, and value. You kind of have complete access to your physician. So he actually texted me and he said, "Hey, can you call me?" So it was towards the end of my day. I just called him. He said, "I think I have a hernia." And, I fell off the wagon too. My blood sugars are awful. I said, "Oh, what makes you think you have a hernia?" He said, "Well, I was going to the bathroom, I was having a bowel movement. I felt a pop in my belly and it hurts." And I said, "That's pretty classic hernia. It sounds like a hernia to me for sure. Are you vomiting? Do you have a fever? Do you feel well otherwise?" He's like, yeah, I feel fine. I just have a little bit of pain, especially when I move around." He's like, "Yeah, it definitely sounds like a hernia. Now, I can't see you tonight, but tomorrow night I'm booked, but I'll just come at the end of the day. I'm done at 6:30. Just swing by. I'll take a quick look at it." He's like, "Perfect." So he comes in, he walks in at 6:30. He's like kind of limping. When I first looked at him, I thought, this guy doesn't have a hernia. So I brought him back to the office and I examined him and I said, "Oh my God, you have a huge abscess. It's not a hernia at all. You have a huge abdominal abscess." Now, for your viewers out there, if you have blood sugars that aren't really well controlled, you have increased risk of any infection, whether it's an infection that you get as a cold or it's an infection that you get when you hit your skin,
Right.
So you have an increased risk of infection when you're a diabetic, and it's much worse if you're a poorly controlled diabetic. So like I said, he kind of fell off the wagon. So I saw him and I said, I don't think we can manage this as an outpatient. I think the best way, and luckily he had insurance. He did have health insurance. I said, I think the most effective way to manage this is for you to go to the ER and get a CAT scan and get some blood work and just see where we're at. He said, okay, I'll do that. So he went to the ER and actually called up the ER ahead of time, and I told them everything, and they were, very happy and appreciative because, most family docs don't have time to do that because they're stuck in this system that, doesn't allow that. So he got there and they admitted him. Now, the interesting part of this whole story, and I'll take no credit for this, is that the next day he had a heart attack. Had nothing to do with what happened or what I took him to the hospital for. Actually, he had a heart attack 2 days later while he was in the hospital. Since he was in the hospital when he had that heart attack, he was, coded and immediately transferred to the intensive care unit and intubated and put on pressors. So he was intubated in the ICU, put on pressors. And the only reason, he came in, it was interesting. He came to see me when he got out of the hospital. And I read everything. And I said, "Oh my God, what happened?" He said, "You saved my life." And I said, "I don't think I saved your life. There was some divine intervention there." But, we kind of had this, when we talked before, is that, I don't know if I saved his life, but I feel like direct primary care might have saved his life, because I think in the traditional model, I don't know. I think I would have, if he would have called me and I would have talked to him, which in my old model, I talked to patients on the phone too. It wasn't unheard of because I was in private practice. I think I would have put him on my schedule, but it would have been 5 days later. It would have been a week later. I'd have been like, it sounds like a hernia. Just if you develop a fever or you start vomiting, call me earlier, but I'll see you on Friday, or I'll see you, in a week. Let me know if any of this happens. But in DPC, I was like, yeah, just come at the end of the day. I'll see them. So I think, DPC might have saved his life in that particular instance.
Yeah, sounds like access probably did for sure.
Yeah, access. Yeah, one of the tenants. Yeah.
Yeah, if he wasn't, if he was that serious and intubated and all that, I mean, if he was at home, he would have died. Probably, right?
Without a doubt. Without a doubt.
Yeah. So tell us a little bit about so people can understand how serious diabetes is.
Right.
Diabetes puts you at risk for cardiovascular disease, correct?
Yeah, absolutely. I mean, and unfortunately, the presenting symptom for most men that have a heart attack is death. They have a heart attack and they die.
And how
that happens a lot.
Yeah. Can you tell us how old this patient is?
Yeah. He late 50s. Yeah.
Okay. And when did he start developing problems of diabetes?
Oh, in his late 30s to early 40s.
Yeah. Okay.
Yeah.
Wow. Well, thank you for sharing that story, and thank you for
Yeah.
helping a patient, being there for him so he could access care. And we hear a lot of stories like that from direct primary care doctors. And you just,
Yeah.
like you say, a lot of those patients just might die if they didn't have access. So, Jen, do you have some questions for Dr. Hampton?
Yeah. So I am interested in maybe another success story of getting somebody off of their medication.
Yeah.
Any of the clients that, working together, what outcomes brought them to a point where they could get rid of something.
Right.
In
Absolutely.
their
So, well, it's interesting. I came across someone in my community, and she was actually an owner in a gym. She moved back to the area. She was in the service for a while. She was a Marine, and her husband was a Marine, and they ended up purchasing a gym because their passion was exercise. They're both heavy, like Olympic lifters, so to speak. And we talked about ways to kind of like join forces, because I really think it takes a village, quote. And I think a comprehensive approach is really the best type of medicine. And sometimes you have to prescribe a barbell. You have to prescribe exercise.
Right.
You know what I mean? Like,
yep, absolutely. I love it.
And we talk about that too. Like, you need to move. I really think that the majority of good health comes through diet. I tell people, they say, "Oh, I don't have time to exercise." I say, "All right, I can get you to lose weight with diet alone. You don't have to go to a gym at all." But this person was younger and they were overweight, and they were probably close to being on insulin. And it's happening younger and younger and younger. And they said, I don't know what to do. And I basically, not me, we created a situation where, we helped her to feel comfortable in a gym setting, and we set her up with a personal trainer and then got her involved with the gym membership. And we kind of had a comprehensive approach where we not only use, office visits, we use, a good dietary plan. And she's a nutritionist too, the woman I was working with. And we use exercise. And this person was actually able to lose around 85 pounds. And they got off 2 hypertension meds, and they got off their oral diabetic meds as well. Still on metformin, but to get off everything except for metformin is awesome, in my opinion.
It is.
Yeah.
That's an incredible success story. And a lot of people don't realize that because unfortunately their doctors don't take the time to do what you did. And I mean, a doctor partnering with a gym should be common, but it's not. Because like you say, doctors write prescriptions. It doesn't have to be a medication. Write a prescription for a barbell or for jogging or whatever. Yeah,
I can't steal that quote. She came up with it. But yeah, I mean, that's what it comes down to. We tried to write a plan, and, I'll be honest, it had varied success, where we basically said, hey, you can have complete access to a doctor 24/7. You can have a gym membership, and you can have advice on, nutrition and all these things. And it's going to be this amount per month. When you add all those things together, things get a little pricey. But, we did come up with a plan, and I would like to say that it, worked out perfectly. But, I think the biggest hurdle is money. And sometimes people can't invest that much money to a comprehensive plan, but it did help a few people out there. We were happy to provide it to the community.
Well, and I think one thing, when you talk about value of your practice, I know direct primary care, I don't know what your fees are. You can get into that a little bit later, but it's really, really very affordable. And, it's about the same price as a gym membership usually. Now, when you throw a personal trainer in there, it gets a little bit more expensive. But when you look at just the cost of medications alone that she got off these medications, even if the insurance was covering them, she was probably paying, anywhere from $5 to $10 to $20 copay or plus a month.
Right.
And then when you look at the opportunity cost, that's priceless.
Absolutely.
That part is priceless. So even if the fee is $300 a month, it's like, if you don't do something now, you will end up spending a lot more than $300 a month.
Well, yeah, it's like that quote: "You can either pay the farmer now or the cardiologist later." You know, I mean,
I love that.
Yeah.
I'm gonna steal that one. Is that okay?
I stole it. You can steal it. I don't come up with anything.
It's totally true, but I think, in our culture, we want an instant gratification, instant
Oh,
fix.
absolutely.
And I'm
Yeah.
thankful that we do have pharmaceuticals that work well. However, when we're talking about chronic issues, a lot of times the lifestyle changes are really the drug of choice, because that side effect is not going to be, that 10 pounds that you got from taking the insulin, that's just because you're on the insulin, or the side effect of the drug that causes you to have, XYZ because you're on that. So we're not chasing another drug with another drug. We're
Right.
chasing a goal that's going to give a lifetime effect, because I think I've heard different statistics, but even just 10 pounds, what it changes in somebody's cholesterol values or lipid values is amazing. And so,
Right.
those are changes that are without side effects,
Right.
that
Absolutely.
I know it's not instant, and I understand that, our culture, craves that, but sometimes when we put the hard work into it too, the outcome is very rewarding, because they took ownership in their body and their outcome and how they feel and how they, that's, I guess, the reward of doing what Sean and I have done over the past years, is that when we hear patients come in and they're super excited because they made a difference in their life, and it
Right.
is adding years of quality, not quantity perhaps, maybe, but quality as well.
Yeah, absolutely. And I know you guys do like hormonal balancing. I'm a big fan of that. But, I'm a big fan of adding that. Like I said, the pyramid is the next step up. Because, like I tell people, like they'll say, hey, should I take should I take a multivitamin? Well, yeah, but you can't eat McDonald's every day. You know what I mean? You gotta,
Right.
it cancels out, man. Like, you got to eat well. You got to sleep. You got to do a little exercise, and then we can talk about multivitamins. And, I'll tell people that, I'll say, listen, other people are selling you something. They're selling you instant gratification. They're selling you a quick fix. They're trying to sell you something. There is no shortcut. The first step is the first step. And, the second step might be hormonal balancing. And that's great. I'm a big fan of that. And I really think, I think it's going to take a while for evidence-based medicine to catch up to that. But I really think it will after time, where people do get better with some of these changes through medications or hormonal balancing. I really do think that's going to be a big step of medicine moving forward.
Yeah, of course we do too. Of course, speaking of selling something, that's
Not
what we
biased
sell. Yeah, I mean, I'm to be honest, but we've helped thousands and thousands of patients, and we have a passion for it. But we'll be honest with our patients up front. It's like, look, this is a piece of the puzzle. Okay,
Right, absolutely.
This does not give you, a right, or it does not give you,
pass go free.
a free pass to eat all you want and not exercise. I mean, this is going to help, but it's a piece of the puzzle. And, I think hormones are an important piece of the puzzle. But as you said earlier in your show, hormones are we use that definition pretty broadly, but hormones are so broad because hormones do so many things. It's, and there's so many different hormones too. So that's why we focus on it, because it's exciting and there's a lot of value that we can add to our patients' health. So, So we're kind of wrapping up our show here, Dr. Hampton. I appreciate you so much. Let me tell you, you are a perfect guest for our podcast, because you have, what you do and what you do with your patients is exactly what we do here. And we just like to educate and empower patients that they're in charge of their own health. So that not only means their own health decisions, but also their financial decisions when it comes to healthcare. So choosing a doctor like yourself, or shopping around for somebody that can do services like you. So talk about DPC and talk about your fees. What are your fees? How you talk about value, how affordable are you?
Absolutely. So, when I opened, I realized the location where I was, and I figured out my fees based on that. So I think when we opened, we had some of the lowest direct primary care rates in the state of Pennsylvania. Our average per patient per month is around $55 per patient per month. Now, we do have age-based pricing, so it's a little cheaper for the younger people, a little more expensive for the older people. It's 18 to 45 and then 46 to 65. So it's about $55 a month. But, what that buys you is direct access to a personal physician. Like I say, it's cheaper than a Starbucks edition or less than a cup of a coffee per day, so to speak. It gets you 90% off insurance, 90% off labs, and even compared to insurance, because if you have insurance, your labs are more expensive than at my practice, believe it or not.
Absolutely.
People are amazed by that. They're like, what do you mean? It's cheaper. It's much, much cheaper. And then we do dispense meds. We're not pharmacists, but we can be a dispensary in the state of Pennsylvania. So we dispense generic, non-controlled medicines, no narcotics, nothing like that. And we dispense those at cost. And then another thing that I do is I offer supplements at my office through a company called Biotics.
Oh, yeah.
They're great. Not all supplements are created equal.
Nope.
And I tell people, if you go to Walmart and you're buying your supplements, it might not be as good. So, we do offer supplements at cost. And one of the things I really push on people is your vitamin D levels need to be good, and we need to check those labs. So, that's just one example. And, I think with that comprehensive approach, patients really love it. And I think what we really love is it's like an old school family doc with a technological twist. They can see me anytime they want in person, but if they want to text me, they can. If they want to email me, they can. If they can't come in because they want to have a telemed visit, they can do that. So that's what they really love, is that comprehensive approach where they get a little bit of everything under one roof.
And it's so affordable. It's almost to some people unbelievable. I'm sure you get that. We've had many doctors on, and people just can't believe. It's like, are you really a doctor? I mean, how can you be a doctor for, $55 a month? But
I've heard that.
Yeah. And when you think about the value services that you just added, that you just went over there, it's really, and of course, we talk about this all the time. Why would you ever want traditional health insurance? I mean, my wife and I don't have that. We have a health sharing ministry, and health insurance it's a ripoff. It's literally a scam. It's a ripoff. I had Dr. Lee Gross on last week, and he talked about how in Florida you can get an MRI now for $220.
200, it's not that low in Altoona, but
well, I know.
The first one too, but
I was telling the story. It's like, when I first started doing this a few years ago, it was like, an MRI, a good MRI was like $800. Now it's at $220, which just reminds, but as you know, for your insured patients, if you haven't negotiated a cash price and they're using their insurance, patients are paying $800 for an MRI, their copay.
Right.
And they're literally getting ripped off. And I still believe, I still tout it. Yeah. Traditional health insurance is a ripoff. Speaking of that, there is a fix in that in my book. You do not have to be tied to traditional health insurance. Go to Amazon, download my book, Sickened: How the Government Ruined Healthcare and How to Fix It. And there are other options to health insurance. And even if you have an employer that offers you health insurance, there might be a way out of that. But it's up to you, the individual, to negotiate that. So I appreciate you being on today, Dr. Hampton. I know you're busy, so we won't take much of your time. What would you like to sum up in the last minute of our podcast? And how do people get a hold of you if they want to get a hold of you?
Sure. So I'm really easy to get a hold of. That's the technological benefit that we live in today. So my website is hamptonmedicaldpc.com. We have an inquiry sheet there. You can get a hold of us. And then I offer a free 30-minute in-person consultation. You can come down, see our office. We have an office dog that also gets to hang out with us. And, you can just see how it works. And I really think if anybody needs to get better, we just need to really, practice the things that produce, results over long periods of time. And I think you need a really good doc in your corner that can help you, kind of fight through all those things and to figure out what's important, what isn't important, and have a good, step-by-step pragmatic approach to just a better overall degree of health.
Absolutely. I love it. So we got your website streaming up there.
Thank you.
Yeah, we really appreciate you being on, and you've been listening to another episode of Health Solutions with Sean and Janet Needham. Stay tuned for Thursday, 8 to 9 a.m. In Pacific Standard Time, we will have a doctor on who's a urologist, and he is going to talk about some of the procedures urologists do. He's a specialist that is going to be a cash-only specialist soon, which is a great thing that a lot of doctors are doing now to help with the DPCs, because you guys really want to refer to specialists that work with cash and give good cash pricing. We're gonna talk a little bit about vasectomies, because we talk a lot about hormone replacement here, and one of the common questions we get is, oh, we've got a gal that's married, she's in her 40s, she's having hormone-related issues, she's on birth control, and she wants to go on hormones because her hormones are out of balance. Well, the reality of it is that before they can really ever do any hormone balancing, they need to get off their birth control pills.
Absolutely.
So, because that messes up their hormones. So a great option with that is, if they're married or in a monogamous relationship, is a vasectomy. It's not as bad as most guys think. So I really want to have this guy on, because he's going to answer a lot of our questions that we get.
Yeah, that's awesome.
Almost every week. So we appreciate you being on, Dr. Hampton. Stay tuned Thursday, 8 to 9 a.m. And you've been listening to Health Solutions with Sean and Janet Needham.